Oh, welcome everyone. It's a pleasure to have you join us. It's a pleasure to introduce Dr. Emad Ibrahim, who is faculty in the Department of Urology, Andrology, and Sexual Medicine, and the Laboratory Director in Andrology in the Department of Urology. Emad has a long-standing history of engagement in Miami project programs, notably his collaboration with Dr. Nancy Brackett and Dr. Chick Lin, who recently retired, and he has expressed an interest in carrying on the legacy of that laboratory, both in its research activities, and he's already submitted work for funding of ongoing fertility studies in spinal cord injury, and also integration with the Department of Rehabilitation Medicine with Dr. David Gator and teaching of these methods to residents and other visitors to the center. So it's a pleasure to welcome him today, and he'll be presenting on reproductive and sexual dysfunction in men with spinal cord injury. Dr. Ibrahim, welcome.
Thank you, Dr. Nash, for the introduction. Good afternoon. Welcome, everybody. Today, we're going to talk about reproductive and sexual dysfunction in men with spinal cord injury. And before we start, we have to really recognize the efforts from these two pioneers, Dr. Nancy Brackett and Dr. Charles Lin. Dr. Brackett started this program back in 1991 and joined shortly after that with Dr. Lin. And most of the science and research that we're going to talk about today is because of their efforts, hard work, and dedication to management of fertility and issues with the males after spinal cord injury. And of course, I got to mention also Mr. Abala. For most of you who know him as Sonny, he's the backbone of this program, and he continues to assist me. And nothing would happen without his dedication as well, and his excellent connections with subjects and patients. So we're going to start by just giving you a little bit of statistics. This is in the United States. We have approximately 18,000 new cases each year, and about 300,000 people living with spinal cord injury. Common causes here in the United States, it's variable. These are the general statistics, but it starts with number one, motor vehicle accidents, followed by falls. Violence, including gunshot wounds, come third. And then lastly, the tie between sports-related injuries and other causes of injury. The majority are young men. And in a survey by Dr. Kim Anderson asking subjects with spinal cord injury to rank 7 functions in order of importance to their quality of life, out of 680 respondents, sexual function was ranked number 1 among paraplegics and number 2 among tetraplegics, only coming second to regaining arm and hand function. Women with SCI can conceive and deliver children with nearly the same success rate as the general population. There are no issues, except they are considered high-risk pregnancies. So at the end of the pregnancy in the 3rd trimester should be carefully monitored, admitted a little bit earlier, and some considerations are taken regarding autonomic dysreflexia and anesthesia as well. On the other hand, the majority of men with spinal cord injury cannot father children naturally. There are 3 main contributors to this condition: erectile dysfunction, ejaculatory dysfunction, and semen abnormalities, and we discuss them all in this talk today. Starting with erectile dysfunction, there are 2 types of erections: reflex erections and psychogenic erections. Reflex erections are mediated by the parasympathetic nervous system and requires intact S2 to S4 nerve roots. They are produced by direct stimulation of the penis, and they are independent of any erotic stimuli. They generally present in injuries above L2, so the majority of men with spinal cord injury that we see in our clinics and in our research would have some sort of a reflex erections. On the other hand, psychogenic erections are sympathetically mediated, and they require intact thoracolumbar nerve roots, and they are produced by thoughts and erotic stimuli. So they are totally independent of direct stimulation of the penis. And because they require the intact thoracolumbar, the majority of the injuries are in between the thoracic and the cervical cords, And that type of erection is the one that is really lost in the majority of men with spinal cord injury. The cyclic GMP is responsible for the vascular changes which occur in the corporal cavernosa and results in erections. And it's hydrolyzed by PDE5 to GMP, which results in the loss of the penile tumescence. And there is a role for the PDE5 inhibitors that we're going to talk about in the treatment of erectile dysfunctions in men with spinal cord injury. First, we start as in the general population with any other causes of ED, with oral medications, which are the PDE5 inhibitors. Sildenafil citrate is the best proven effectiveness. It's the most drug that is studied in SCI-related erectile dysfunction or in any causes of erectile dysfunction, followed by the tadalafil, which is called the weekend drug, but it has an unusual side effect of backaches. Vardenafil hydrochloride is effective for 4 to 6 hours. And the most recently approved FDA medication, PDE5 inhibitor, is avanafil, but we don't have any data on its use with SCI patients. If the patient have side effects, cannot tolerate oral medications, or don't like it, then we resort to intracavernosal injections. It's either monotherapy in the form of prostaglandin E1 single shots, or Trimix, which is a combination of prostaglandin E1, piperacillin, and phentolamine. Also, we have to be careful when we prescribe intracavernosal injections for tetraplegics who have poor hand dexterity, or we can train a partner to inject the patients and proceed with the erections. Intraurethral applications, this is least favorable by men with spinal cord injury. It's in the form of prostaglandin E1 suppository that's placed in the urethra. And it's because the majority of men with spinal cord injury would have bladder management in the form of clean intermittent catheterization. So they don't like to introduce another element into the urethra. And on the same time, also the urethra is not perfectly healthy and the absorption varies from one patient to the other. Vacuum erection devices using restriction bands is also one of the non-invasive treatments and therapies for ED. Men with spinal cord injury has to be cautious toward removing the restriction bands right after sexual encounters. If all these fails, then penile prosthesis would be the option, and the decision between the malleable semi-rigids or the inflatable prosthesis would be between the patient and his surgeon, and it depends on also hand dexterities because the inflatable ones would require inflating and deflating the pumps, and also a partner can play a role in this issue. We're now going to turn into ejaculation. As you know, there is 2 phases for ejaculation: the emission, which is controlled by the T10 to the L2, and it's sympathetically controlled. The expulsion is by the S2 to S4, and it has sympathetic, parasympathetic, and somatic contributions as well. The spinal ejaculation generator is covered by scientists first in animal studies in the mid-lumbar segments, and it was assumed to control the sympathetic, parasympathetic, and somatic outputs. Then lately in the 2017 group of French researchers did a human study where they examined postmortem spinal cord segments from 6 men and 6 women, and they were able to identify the spinal ejaculation generator between L3 and L5, and they were able to correlate that with success in PVSs in 384 men with SCI. How do we manage the ejaculatory dysfunction in men with spinal cord injury? There are methods to retrieve semen or sperm from this population. We start by the penile vibratory stimulation. There's electroejaculation. There's prostatic massage and surgical sperm retrieval. Either you extract it from the testis or from the epididymis. So what are the pros and cons for each method? I'm going to start by the penile vibratory stimulation, which is the method of choice. It is safe. It has an 86% success rate if the level of injury is a T10 or rostral. It's fairly inexpensive. You just only have to buy the vibrator one time. It can be performed at home after we train the patients to control the side effects if you have autonomic dysreflexia as well. It yields the highest total motor sperm count. And please remember this term total motor sperm count because we're going to use it a lot in this talk because it's very crucial when it comes to fertility statuses and the treatments afterwards. It have very low success rate when the level of injury is below T10, caudal to T10. And of course, the autonomic dysreflexia, we have to be careful with it. For the electroejaculation, it's also safe. It has a nearly 100% success rate, but the startup equipment, the cost of the electroejaculation machine is a little bit high. It's an invasive procedure, and the risk of autonomic dysreflexia is still there. And remember that this has to be only performed by a trained physician, and it yields lower motility. So the total motor sperm and the motility is lower than the penile vibratory stimulation. Prostatic massage does not require any specialized equipment. It is easy and fast, inexpensive, but there are few reports about it, inconsistent results, and there is no documentation of autonomic dysreflexia with it or without it. Still, it's a stimulation below the level of injury. Surgical sperm retrieval, no specialized equipment is needed. It may have less autonomic dysreflexia in some patients, but it's a higher cost and it has to be performed by a urologist. It leaves very low total motor sperm, which results in commitment of the couples to the highest cost of assisted reproductive techniques. So what is autonomic dysreflexia? Injured patients that have injuries T6 or rostral would develop with any stimulation below the level of injury, such as penile vibratory stimulation or electroejaculation, or even a full bladder, would develop massive sympathetic response in the form of widespread vasoconstriction that causes hypertension. Then there is a response from the baroreceptors in the aortic arch that sends signals to the brain. The brain would slow down the heart and normally would send descending inhibitory signals, but these signals are blocked by the injury due to the nature of the injury. So the hypertension continues to dangerous levels. The bradycardia and sometimes even tachycardia would happen with flushings, and sometimes it reaches dangerous levels that are life-threatening. In our protocols, we always pre-treat patients who are T6 or rostral with nifedipine prior to stimulation, and that controls the hypertension and avoids the dangerous effects of autonomic dysreflexia. Penile vibratory stimulation is the first line of treatment, as we mentioned before, and there are multiple vibrators that can be used by the patients. They can be used by hand massagers. They can be head massagers. They can be used by vibrators from the sex shops. And a lot of patients would ask, why do I specifically need to get this vibrator that is super expensive compared to others that are in the market? And we have even patients that use Mr. Potato Head that you see here in this picture, and he was able to successfully ejaculate using it. But the whole concept lies in the amplitude. The amplitude, as you see here, Dr. Jan Sonsken, who is an MD PhD from Denmark, who has studied this amplitude extensively, and he established that the optimal amplitude is a 2.5 millimeters traveling from the device to the head of the penis was the key factor in success of ejaculation using a vibrator. So he engineered and marketed a higher amplitude vibrator because most of the other vibrators are very low amplitudes. He manufactured it and became available commercially in 1995. And most of the studies that you see in the literature are done by this device, but this device was not produced anymore when the manufacturers did not manufacture it, and it was stopped. And for a gap of time, we didn't have any new vibrators till the introduction of a new version of the Ferticare, as you see in this picture. It's called the Ferticare 2.0. It's manufactured here in the United States by Reflexonic. And we decided that we want to check the efficiency of this device before saying if it's working or no. So a panel of 10 world-renowned experts from the US, Canada, Denmark, and Sweden assembled here in the Miami project in the University of Miami to evaluate this device. We tested it on 15 men with SCI. All subjects previously responded to other vibrators, ejaculated with the Ferticare 2.0. There was very well tolerated. There were no complications. And all the subjects, actually, when they are asked, do you recommend this vibrator to other men with SCI, they all agreed and they all recommended it. And currently, it's the only device that is available that is marketed for penile vibratory stimulation in men with spinal cord injury. So how do we do penile vibratory stimulation? First, as we talked before, remember to monitor against autonomic dysreflexia. So if the patient is a T6 or rostral, we give them 20 milligrams of nifedipine. Patient is placed in the bed, bladder is emptied, and a buffer is added. For the first time, we do this trial, so to check against if there's any retrograde ejaculation or no. The vibrator is applied for a maximum of 2 minutes at a time. Most patients respond within 2 minutes if the level is T10 or rostral. Vital signs are monitored. If there's no ejaculation, after 2 minutes, it is stopped. The penile skin is inspected. If there's any side effects, if vital signs are unstable, or if there's edema, it is totally stopped for the day. If there is none of this, then we can resume vibratory stimulation in 2-minute increments for an cumulative time of 10 minutes. And then we collect the antegrade specimen in a cup. We cath the patients and we empty the bladder, we spin it, and we get the pellet and we check for the retrograde ejaculation. What if one vibrator doesn't work? We tried and we published data on using 2 vibrators at the same time, one at the dorsum and one at the frenulum, and it salvaged some failures to one vibrator. There's another device in the market, as you see here, it's a Vibrect X3. It was commercialized in 2013. It's currently not available, but it might be available sooner. We don't really know, but the whole concept about it is it has dual pads, so it would work the same way as the 2 vibrator methods that we have here. We did 2 independent studies, and we found that the success rate using 2 vibrators would about be 86%. The Vibrect has a little bit lower success rate, but it's still successful. We also reported 2 case series about using abdominal electrical stimulation simultaneously with penile vibratory stimulation, and it salvaged some and rescued some failures using only a single vibrator. If penile vibratory stimulation fails, the patient is referred for electroejaculation. As you see here, this machine is called the Seeger electroejaculator. It's model 14. And the name is referred to the Dr. Steven Seeger, who actually popularized and refined this for humans after it was used for many, many years by him in the veterinary medicine. And it's been used since that time, and it's excellent device. It's same as any other procedure. We first assess the patients for risk, pre-treat with nifedipine if there is history or the suspicion of autonomic dysreflexia. The bladder is prepared. In this condition, the patient is placed in the lateral decubitus position. Anoscopy is performed to check the health of the anal orifice and the rectum. The probe is placed in the rectum. The current is delivered, and then the antegrade and retrograde specimens are collected. And there is a high chances of getting also a retrograde specimen with this procedure. So which one is better? Is penile vibratory stimulation better than electroejaculation, or the other way around? Both procedures are simple, they're effective, and relatively safe. They both carry the risk for autonomic dysreflexia depending on the level of injury, but the EEJ has the advantage, electroejaculation has the advantage that it usually works when the vibratory stimulation fails, and there is no risk of penile skin damage, though there's some risks for the rectal mucosa. While the penile vibratory stimulation is preferred more by patients, it is less invasive, has a better semen quality, and of course they can use that to attempt home insemination, while electroejaculation is harder to do that because the patient has to come to the clinic, perform the electroejaculation, and then they can take the specimen and try it at home. So it's simpler for them to try it more frequently if they are trained to use the vibrator at home and get an ejaculate. So what kind of semen quality did we talked about? So we talked about erectile dysfunction. We talked about ejaculatory dysfunction. Now we're going to have to talk about the semen quality. There were numerous studies about semen quality. In our group, we examined over 700 men with spinal cord injury. We performed over 3,700 penile vibratory stimulation procedures and over 2,600 electroejaculation procedures. What we've seen and observed are changes that are macroscopic, microscopic, and in the parameters. Macroscopically, as you see in this picture here, there is different colored semen. This is brown colored semen and happens about 29 to 30% of men with spinal cord injury. And that does not affect the changes in the pattern. It's the same picture. It's only macroscopically looks different. Microscopically, under the microscope, you would see a lot of debris, round cells, and the majority of the leukocytes. So you see a lot of white blood cells. Leukocytospermia is very predominant in this population. And most importantly, when you check for the sperm parameters, you'll have this unique picture that is only in men with spinal cord injuries semen, that you have normal total counts, as you can see in the bar graph to the left, but you have statistically and significantly lower motility and viability. The attention was directed, most of the researchers were thinking that the poor semen quality might be related to the changes in the lifestyle following spinal cord injury. Is it due to methods of bladder management? As you know, some would do clean intermittent catheterization, some will have an indwelling catheter, some will do suprapubics, some will do voiding. So is it due to that? Or is it due to being in a wheelchair for extended periods of time, causing scleral hyperthermia, and that affects the sperm quality? Most of them don't ejaculate frequently. Is it due to infrequency of ejaculation, or which type of method that they use for ejaculation? Is there a difference between acute and chronic injuries? And based on the majority of the studies, lifestyle factors did not seem to influence the low sperm motility in men with spinal cord injury. Even hormonal profiles were performed, and the different hormonal profiles, but the similar semen profile as it does not change with the hormonal profile changes. In this interesting study done by Dr. Brecker, Dr. Lin, and the group, they thought that maybe the cause of this anomaly and this low motility and viability could be due to factors in the seminal plasma. So the research was directed a little bit towards studying the seminal plasma and seeing what is it affect. Is it toxic? Is there something wrong with it? So in this study, seminal plasma from men with spinal cord injury was mixed with sperm cells from control subjects. And surprisingly, the motility of the control subject's sperm dropped dramatically after adding the seminal plasma from men with SCI. On the other side, the seminal plasma from control subjects was able to recover motility from men with spinal cord injury. So that directed the attention towards some issues with the seminal plasma. In order to confirm these findings, they aspirated some sperm from the vas deferens and compared it to ejaculates from the same man with spinal cord injury. And as you can see here in these graphs, there is statistically significant lower motility and viability between the sperm that is aspirated from the vas deferens and sperm that is ejaculated in red and in green in these graphs. What is the prostate the culprit? They performed biopsies from the prostate of control subjects and SCI subjects, and found no evidence of inflammation. They went and studied and examined the PSA concentrations in both men with spinal cord injury and controls. So serum PSA was higher in SCI than controls, but the seminal plasma PSA was significantly lower in SCI than controls, that indicates a possible secretory dysfunction of the prostate gland in SCI. We collaborated with our colleagues from Sao Paulo University in Brazil to perform quantitative proteomics of SCI seminal plasma. This was done using mass spectrometry-based quantitative proteomics on seminal plasma of 12 SCI subjects, and the identified proteins strongly suggest that there was strong activity of immune system, and it's not triggered by microbial infection. The explained possible explanation for the low motility would be due to induction of protease inhibitors, a loss of proteases. At the same time, the secretory function or dysfunction of the prostate gland was confirmed by decreasing the kallikreins that they found in the seminal plasma of men with SCI. Another study by Dr. Dana Ohl, who's an expert in this field as well, who studied the seminal vesicles, another accessory gland, by aspirating from the men with SCI, and they found abnormally high numbers of sperm in the aspirate, which indicates an abnormal transport and storage of sperm in the seminal vesicles of this population. This group as well, the Miami Project group with Dr. Brackett and Dr. Lin and colleagues, they examined the leukocytes that are present in the semen of men with spinal cord injury using the cytofluorographic identification, and the majority mostly were activated T cells, which are known to produce cytokines. So they went and examined and the cytokines in this semen of this population, and not surprisingly, they found extremely elevated levels of pro-inflammatory cytokines, IL-1 beta, TNF-alpha, and IL-6. When these cytokines were neutralized in vitro in a cup using either monoclonal antibodies or receptor interference agents, the motility significantly increased and improved by these neutralization efforts. So their thinking was, what is the mechanism that leads to these elevated cytokines in the semen of men with SCI? Is the inflammasome complex involved? Collaboration with the distinguished researchers here at the Miami Project and the University of Miami, we studied the inflammasome complex, which is a multi-protein complex that leads to activation of the caspase and event results in the release of IL-1 beta and IL-18. The study showed that semen of men with SCI had higher concentrations of caspase-1, ASC, and pannexin-1. We identified also to confirm the findings by doing immunocytochemistry and confocal microscopy, and ASC signals were detected in sperm of men with SCI, but not in controls. Caspase-1 as well was detected in SCI sperm and not in controls. Linear regression analysis showed that the sperm motility was significantly correlated with caspase-1 and ASC as well. When we added anti-ASC in vitro to semen from men with spinal cord injury, we saw significant improvement in the sperm motility. As we mentioned before, pannexin-1 signals were also detected in higher levels in men with SCI, and the pannexin-1 channel plays a role in the activation of the inflammasome complex. We tried probenecid, which is a drug that is well established for the treatment of gout, and at the same time it blocks the pannexin channels. We did a pilot study where men with spinal cord injury were given oral probenecid for 4 weeks, which is the regimen usually used for simple gout. Semen quality was analyzed before treatment, after treatment, which is after 4 weeks of probenecid, and then in a follow-up visit, which is 4 weeks after stopping the probenecid. It was very well tolerated. The motility improved in each subject. And as you can see in this graph, the greatest improvement was seen in the rapid linear motility, which is important in any reproductive endocrinology techniques that are used, assisted reproduction. The rapid linear motility is the fastest moving sperm in this population. We also wanted to check and see how does the probenecid work, and again collaborated with our colleagues in Sao Paulo University in Brazil. We did a shotgun proteomic analysis of the seminal plasma from 9 probenecid treated men with SCI. So these are men who we treated with probenecid, we have the semen before and after treatment, and found that 17 proteins were decreased and 6 were increased after treatment. And the main theory was this because in men with SCI, they found higher biglycan, which is an extracellular matrix protein that activates innate immunity. After treatment with probenecid, the level of cystatin S increased, and this caused the biglycan levels to drop. It decreased the innate immunity, and hence would be a possible mechanism for improving the sperm motility. So why are we studying all this? Because we want to give better options for couples who have a male with spinal cord injury. It's interesting, medical and ethical problem comes with this concept. When an able-bodied man goes to a fertility doctor and to check their fertility status as a couple, the first thing that they ask for is get the ejaculate and examine it. That does not happen with men with spinal cord injury, though there are methods that can be done. As we mentioned before, you can have a prenatal stimulation, we have electroejaculation, get that, look at it, it doesn't happen. And when we ask practitioners who deal with men with spinal cord injury in general, and we ask them, why don't you offer PVS? The answers was either we don't have a PVS equipment, or not aware and not trained. When we asked about electroejaculation, it's even worse. They don't have the equipment because we said that the cost is a little bit expensive, but also they are not trained, and the referral would consider logistic problems to them. If we resort to surgical sperm retrieval, which is the next method to do that, then here's the problem. It's the first most invasive and most expensive option because the number of sperms that are retrieved with these methods are low enough that they're not going to be able to be used in other methods. But if we have an ejaculate, we can have the option of either doing intravaginal home insemination or intrauterine insemination. When we ask the same practitioners in the same survey, what is your cutoff number for total moral sperm count to be used in intrauterine insemination? The majority would say consider between 1 to 10 million total moral sperm count. So if we take 5 as our cutoff point for most of this of the practitioners, and we study the ejaculate and the number of total moral sperm that comes from the ejaculates of about 1,700 trials that we performed here in our program, we find that the majority of them will have higher than 5 total moral, as you see in this graph here to the right. So 5 and higher is the majority. In the survey, we asked them, do you counsel couples to attempt home insemination? 54% said no. And when we asked them to counsel about an IOI, 34% said no. If we even resort to IVF and ICSI, the sperm that is obtained non-surgically from the patient with spinal cord injury can be used easily and safely with ICSI. And if there are embryologists listening or people who enrolled with embryologists, it's always recommended to see motile sperm in there. If you get a testicular sperm, you rarely can see motile. It may be twitching because it's still not mature. Here we get mature sperm. There's motile, easily identified and easily used in ICSI. So still, we have to look for the ejaculate. The key points regarding the pregnancy rates. So we have to realize that intravaginal insemination, home insemination, the 25 to 70% per couple, which is very, very similar to able-bodied or other male, let's say other male factor couples. Intra-insemination, same thing, success rate is the same. For the IVF and ICSI, if we do penile vibratory stimulation, remember we talked about higher motile sperm, so it's same as a non-SCI male factor, while with electroejaculation, it's slightly lower than the non-SCI male factor. So what are our take-home messages from this? There are treatments that are available for erectile and ejaculatory dysfunction in men with spinal cord injury. These men present a unique infertility population. Remember what we talked about. It's very unique to find a total number of sperm, the count is normal, but extremely low, severely low motility and viability. It's impaired. There might be some toxic elements of the seminal plasma as we discussed, but technologies are available to overcome the deficits and assist consumption. And the choice of technology is going to be controversial. We try to advocate for trying first to get an ejaculate, do home insemination if there's enough total motor sperm, or at least intrauterine insemination. The cost is dramatically less invasive, less complicated, and less side effects. So what the future and directions of this project? And Dr. Nash alluded a little bit to what we have in mind. This is, of course, the picture of the state-of-the-art new Christian Lynn Rehab Center. We are planning in collaboration with the Department of Urology and Physical Medicine and Rehab to do a urology rehab clinic. We'll see the patients there, and we'll give them all the treatments options and all the diagnostic options for their urology rehab needs. We will continue, we'll try to continue and do at least a biannual educational workshop. We did for the last 2 years with Dr. Brackett and Dr. Lynn, very successful workshops for practitioners and people who deal with spinal cord injury on a daily basis to treat them, to teach them how to perform penile vibratory stimulation after ejaculation. We actually did workshops on patients here, and there were subjects that were volunteers, and it was very successful, and we will try to continue doing this as biannual workshops here. We also applied for a grant and to study and do a placebo probenecid, a placebo-controlled clinical trial where we are going to try to use, as we mentioned, we only used a single dose. That is the one that is used for gout. So we're going to try to do different doses, and we'll try to give it for a longer period of time instead of only 1 month. And then also in the study, we propose that we are going to do sperm safety studies such as DNA fragmentation and check the levels of the ROS in the semen specimen. We also want to involve heavily the big population of infertility patients that we see in the urology clinic. And we would like to get the specimens and use it to study the inflammasome and to see the components and if there's any effect in other male factor etiologies. We also want to expand the program to include sexual dysfunction, urogenic bladder, and bladder cancer screening tools and markers. And well, thank you for your attention, and I will willing to answer all your questions through the chat. And at the same time, also, these are my contacts, the email, the Twitter handle, and the Instagram. If you want to ask any questions in the future, I'll be more than happy to answer the questions.
Thank you, Dr. Ibrahim. So if you have questions about the seminar, please submit them through chat.
All right, so there's a question here about semen quality. Is it better with penile vibratory stimulation or electroejaculation? It's better with penile vibratory stimulation. The motility is better. The volume is higher. And you have more antegrade, which is coming out of the penis with the penile vibratory stimulation than with electroejaculation, because of the nature of the procedure. With electroejaculation, you tend to have retrograde ejaculation more than antegrade. But they're both better, definitely, than surgical sperm extraction. Okay, so the question about oral prevents and increased sperm motility to within normal limits, it improves the motility than the baseline. Reaching normal limits, we have seen only in few patients, but that depending on the starting motility, because sometimes we have patients that start with an extremely low motility, like 10%. So if we improve the 10% to 20%, that is double. But still, that's why we are submitting this grant in order for us to study it for a longer period of time and with different doses, you might have a better response. Is there a specific spinal cord injury level that PVS won't work? Yes, if it's T10 or caudal, lower than T10, very low success rate, and that's why we resort to electroejaculation in these cases. Okay, and how does it work related to male infertility in general? So the concept is because we have multiple etiologies for male fertility that are not studied from the molecular level. So we would like to check the inflammasome specifically in these people to see if there is a relationship with maybe varicocele, would be obstructives, and other etiologies that would be helpful. Ideas about the way the parasympathetic network in the sacral region is organized has changed. Do you have any comments about that? So with the issues of the parasympathetic network and in the sacral region, we have two problems with this. It's because when we try to apply our methods of inducing ejaculation, the injuries in the sacral region would play an important role. So that's an excellent question. And that's also some of the relay back from the ejaculation, the ejaculation generator that was talked about in the mid lumbar and going to the lower lumbar, but it should be very interesting to study. Yes, addressing the bladder cancer is important, and we would like to do, and we started something when Dr. Kim Anderson was here, and we would like to actually include patients in a pilot study that we would be examining urine and doing cytology on the urine. We'll be doing cystoscopies, and we'll be doing also urodynamic studies on them to exactly find out if there is something in common. And it also want to do the variations between acute injuries, chronic injuries, and specifically we want to address patients who have been injured for over 20 years, and the method of bladder management also would be contributing to if there's any issues that we will see. But that's definitely something that we have in mind and we would love to do. Cancer in patients with suprapubic catheters. Well, suprapubic catheters in general are, has a lot of complications and a lot of problems. Fortunately, we don't see a lot of them now. Most of the people will try to avoid the suprapubic catheters, but there's definitely areas in the bladder that are damaged because any indwelling catheter would touch the wall of the bladder and will cause some irritations, and this irritation with time might become neoplastic or might change. So that's definitely a higher risk. Okay.
Any other questions?
I don't see any other questions here, I think.
Well, then again, let me thank you for an excellent seminar. Thanks to, oh, you want to get one in?
Okay, so a patient with spinal cord injury C5 or C6 already have some non-motile sperm in urine due to retrograde ejaculation. what are the chances of getting sperm with electroejaculation? So that depends on the way that the bladder was prepped in order to get this retrograde ejaculation. So if the bladder, the urine is very toxic, very acidic, and it's toxic to sperm. So once the sperm touches the urine, it's really going to die in a very short period of time. So that's why when it's not prepared, you'll see a lot of sperm, but it's not motile. When we prepare the bladder, we put a buffer in there that will alkalinize the urine, and that gives the sperm a better chance of surviving than we immediately wash it and spin it and get the good sperm, and then can be used in other procedures. So I think that would answer the question.
Okay, very good. Again, thank you for your seminar. Thank you all for attending. Everybody have a great day.
Thank you. Thank you.
Be well.